third case comes from Widad Abdulwahab, who is an RN and a transfusion safety nurse and officer out of Sunnybrook. She has over 11 years of ICU experience and has completed her master's degree in nursing and has done a lot of numerous clinical and leadership initiatives, including educational sessions. But in particular for TISS, has done a lot of the transfusion reaction investigation and reporting, of which we're very thankful for, as well as being one of the TISS Ontario Education Committee members and a Tracy's Transfusion Safety Officer resource person. So I know has done a lot of work with advancing transfusion practice at Sunnybrook, and again, we're thankful for that and also for this case we're about to hear.
Hi everyone. Everybody's tired. The good news is after this we'll go home. So my case is this 80-year-old female with history of NGO immunoblastic T-cell lymphoma. Can you guys hear me okay in the back? Okay, that's okay. So AITL is a rare type of non-Hodgkin's lymphoma. This particular patient had stem cell transplant 4 years ago. Had isolated B-cell lymphoma, treated with CAR-T about 2 years ago. The patient was started recently on chemo and dexamethasone for relapse of AITL. Admitted in June 26th of 2024 with febrile neutropenia. This patient happened to be chronically neutropenic for many years. Had ongoing fever, hypoxia, and was COVID-19 positive when the patient was admitted. So during that admission time, this patient was admitted or transferred to the ICU because the patient was having hypotension, so required to be on pressors as well as fluid boluses. His symptoms were improved in the ICU. Because of her chronically low BP, she had been getting intermittent IV boluses while she was in the ICU. And then she came out of the ICU when she got stabilized, and by over 24 hours post-transfer to the oncology unit, she was having some increased facial edema as well as generalized edema and some sort of functional decline. This is her medication history. She was on Medidrin for hypotension. They were given to her for PRN. She was also on antibiotic, Victazole, Septra, Bencyclovir as prophylaxis. She was on an aspirin for DVT prophylaxis, and vitamin D, potassium chloride, and Tylenol for fever, PRN. So she received IVIG 2 weeks into her admission. And then the brand was Damagard. The dose was 20 grams. They did not give her any pre-medication during this time, so she did. Okay, so halfway into the IVIG transfusion, she became unwell. So they had to stop transfusion. So the transfusion start time was 12:50. So they had to stop it at 2:15. So this is the history of her transfusion history in the past. So she had received multiple doses of transfusion, red cell transfusion, and while she was in the ICU, she received about 3 liters of crystalloids, which was amylase lactate. Her pre-transfusion vital sign, as you can see, she didn't have any fever, was 36.5. Heart rate was normal. She was on Nasopron 1 liter. Saturation was in like 94, 95%. Blood pressure was normal. But at the time of transfusion reaction, she spiked fever. So her temperature went up to 39.1. I usually check when they spike fever pre-24 hours in post. So she didn't have any fever pre-transfusion, and post-transfusion Tmax was 37.8. So her heart rate went up to 115, so she became tachycardic. A bit of tachypneic, her respiratory rate went up to 22, and then she dropped her oxygen saturation, was down to 86%. At that time, they put her on face mask, like after 50%, still didn't manage to bring her oxygen saturation up. She was starting barely around 91, 92%, and eventually they put her on a non-breather mask, which is, it delivers about 15 liters of oxygen. So they were able to manage to bring that oxygen saturation up to like in the high 90s to 100%. So the clinical symptom that she actually presented, this is just to summarize. So she had fever with rigors. She became hypoxemic, was down to 86%. She had shortness of breath. She had increased water breathing, tachycardia, tachypnea, and she also had expiratory diseases. So this is the clinical investigation that we did. So obviously she was a group A positive, and antibody skin was negative. Blood culture was done, so there was no growth. Chest X-ray showed mildly increased bilateral small to moderate pleural effusion with atelectasis and consolidation. We reviewed the pre-IVIG chest X-ray, which there was no obvious consolidation or pleural effusion. There was no serological incompatibilities from the blood bank side. ECG and echo wasn't done. So the NT-proBNP level was at the time of the reaction, like after the transfusion reaction, it was almost 13,000, close to the 13,000, comparing what it was about 1,500, and then about 10 hours after the reaction, gradually her BNP level went down to like almost to 7,000. We also checked her hemolytic markers because of the spike in fever, just to kind of rule out hemolytic and this IVIG that she had received. So as you can see, it's negative. So hemoglobin remained pretty stable. LDH was normal. Haptoglobin was 1.7, and Billy was normal as well. So the management that we had provided, so like whenever we see transfusion reaction, the first thing we do is stop that transfusion. So they provided supplementary oxygen, high flow oxygen, to up to non-breather mask, and then they continued on the antibiotic, which was on piptazo. They gave her diuretics. So she responded from the notes, from the ICU notes, she responded well. 24 hours after transfusion, her for her fluid balance was negative, so which shows that improvement from the diuretics. But at the time before she transferred to the ICU, while she was in the wards, she had some like increased water requirement, even though she was on 100% non-rebreather mask. Then rapid response was called, and then ICU was involved, and eventually she had to be transferred to the ICU because she needed to be on non-invasive mechanical ventilation, which she was on afterflow. At the time, she required up to 70% of oxygen to maintain her oxygen saturation. So I put it in the note here that she was transferred back after 3 days back to the wards. And they continued to give her midodrine, and still like her blood pressure remained on the soft side, like in the 90s, 100. So bit of IV fluid as well for hypotension. They did give her atropine and Ventolin bronchodilators for the wheeze that she had, and some steroids. So, what is the conclusion of the adverse event? Here, what do you guys think? Very straightforward, huh? Okay. And next one, too. Oh, okay, okay. Right. So I can go next. So relationship, so what is the relationship of the adverse event to transfusion? So more people are saying probable. The severity of the adverse event. We have grade 2 and grade 3. And the outcome of the adverse event.
Right.
And then who should we report this to?
Oh, great. That's not necessary.
So majority of the people saying 38% is saying that we have to report to plasma derivatives, which that's correct. Plasma derivatives manufacturers, TTISS and Health Canada. So we have to report to all three. So this is the summary of our investigation. So basically the conclusion is, yeah, TACO was people expect. We do have a finished hour here as well. So another TACO. Like it was mentioned earlier, 1/3 of patients that has TACO usually have fever with it. So it's hot TACO. The relationship is probable. Severity of the adverse event is grade 3, as the patient required to transfer to the ICU and required to be on a non-invasive ventilator. The outcome was minus to no severity. This is the take-home message I have. So essentially, like identifying patients at higher risk of TACO can help early diagnosis, treatment, and mitigation of its severity. We should always assess patients' food status or food balance because if they are like on this particular patient, the patient had received multiple fluid boluses while she was in the ICU, and the amount of volume that she received is 100 mils. So it's IVIG 100 mils. So it's less amount because she was already preloaded, and that might be the reason as to why she had TACO. Patients can present with symptoms of TACO after transfusion of small volume through a single unit of transfusion. That means other mechanisms apart from volume can play a role in the pathophysiology of TACO. And then there are several hypothesized pathways in which transfusion, as opposed to conventional fluids, can result in circulatory overload. So this information is from Esther et al. And Christine and Jacob and Jeannie Column, the recipe for TACO. So there's a lot of information and really detailed information about other mechanism of TACO. So another take-home message is this includes transfusion product specific factors, including biochemical and inflammatory mechanism, as well as endothelial and vascular interactions with transfusion products can trigger TACO. As due to there might be some damage to the endothelial tissues, and as a result, fluid can shift from the intravascular space outside, and then it can go into the alveoli. So it can potentially trigger TACO symptom. Okay. That's it.
Any questions for Widad?
Two questions, so amazing case. Do you guys tag the involved lot number to put in an instruction to not re-expose the patient to the same bottle if they resume their IVIG at a later date?
Usually we, like, the patients have reactions, so we try to change the IVIG, product.
The lot number or the brand? Do you both?
Usually we change the brand, yeah, but the lot number, I don't think so. Do we, Akash? Yeah,
No, we usually, change the
just the
brand,
brand.
as our first line.
And did you guys get data on how many reactions that particular lot number was involved in? Were other people reacting to that lot number at a rate higher than expected?
I don't think there was any IVIG related reaction associated to that particular.
On that comment, it's interesting.
Go ahead, please.
It's interesting, as I'm working on this 5-year report, 2 comments. One is, we have a secondary reaction admin part where we look through everything and capture it. And to your point of febrile is associated with about that 33% of the tacos. But the other is looking at IVIG lot numbers, and you are to report if you have clusters. As I'm going through it, there are so many clusters and they're different hospitals. So how would you know if you weren't looking at it from our point of view? We haven't in the past gone through unless Ministry of Health has asked us to look or somebody's asked us. But I can look at it's like Sunnybrook, London on all the same lot numbers, and we can see the clusters. So we can do a better job of feeding that back.
We had actually gotten an email from Andrew about a clusters of reactions, because you had seen it